Before you insert the otoscope, inspect the pinna and post-auricular skin. Gently palpate the pinna to find out if any tenderness exists. Now, inspect the entrance to the ear canal for any debris or pus which might interfere with the exam. To make insertion of the speculum easier, you'll need to straighten the outer ear canal. For adults, retract the pinna upwards and backwards. For children, retract the pinna horizontally backwards. Hold the otoscope like a pencil between your thumb and forefinger, with the ulnar aspect of your hand resting firmly but gently against your patient's cheek. This way the otoscope will move in unison with your patient's head if he or she turns or moves, avoiding possible injury to the ear canal. As you conduct the examination, it's normal to adjust the line of sight and the position of the speculum to completely view the entire ear canal in all areas of the tympanic membrane. To help you determine tympanic membrane mobility and recognize many middle ear disorders, sometimes you'll want to use a pneumatic attachment. When you do, make sure you choose a soft spec speculum large enough to fit snugly into the ear canal to establish an airtight seal. Use the same hand position with the bulb of the pneumatic attachment in your palm. By gently squeezing the bulb and observing the relative movements of the tympanic membrane in response, you can obtain vital diagnostic information.
So James, I'll have you tilt your head just slightly away from me. That's perfect. Okay. And the other side. And just tilt your head slightly away. Perfect. Okay.
Okay. Let me know if you feel any discomfort. Okay. So this ear looks clear. There's no earwax. I can see the cone of light. There's a little bit of scarring, it seems, and I can see the bony landmarks. There's no redness. Yeah, this ear looks perfectly normal. I'm going to check your other ear now. Just going to... 1 second. Let me know if you feel any pain, okay? Okay. So this ear definitely looks a lot redder. I can see some dilated vessels, a little bit of scarring as well, and I can see, yeah, I can't see the cone of light, so there's probably some bulging from the back. There's a little bit of earwax too. Okay. So I want to do one more test. Basically, I'm just putting this pneumatic otoscopy attachment in here. And I'm just going to press it a little bit and see if your eardrum is moving properly. Okay. So your eardrum is not moving as well as it should. It has lower mobility. So it seems like it is harder. There's something behind it. Okay.
What we are doing right now with improving our software and improving our hardware is to make it as user-friendly as possible. So really all the mom or dad needs to do is just stick in the kid's ear, maybe jiggle it around a little bit, and there will be images obtained, videos obtained that can be uploaded to the clinician or physician who will actually see those images and make the ultimate diagnosis.
I think that this is even a great idea in an educational setting because students can see exactly what the doctor is seeing when you're trying to learn about how to diagnose things. So I think it's really great, and I think it's something that probably will be used in medicine.
So now we're going to be talking about otoscopy and the proper way to do it. So before you start any of your other exams, you should always start with otoscopy. The reason is that you need to be able to see what's going on inside the ear before you do any of your other exams. The proper technique for holding the otoscope is you want to have a finger, either a pinky or another finger, bracing the side of the face like this. So if you do have a child or an adult who is moving around or uncomfortable with the exam, you're making sure that you're keeping the otoscope in place and you won't injure the individual. So I'm just going to move her hair out of the way and place my finger, and I'm going to go ahead and take a look. And when you get in there, you want to get a good look and be able to see the eardrum. Pull back on the ear so that the ear canal will be more straight when you're taking a look inside the ear. And that's it for general otoscopy.
I'm Abby Sachs, and I'm going to be teaching you how to use the otoscope with the ear. First, you want to place your patient in a position with your head tilted slightly downwards. You want to select the largest speculum that is comfortable for them. You don't want to be too tight or too loose. You want to hold the otoscope with the same hand that you're examining their ear, so my left hand, her left ear. So you're going to stabilize the otoscope with your ring and little finger, and you could either use the hammer or the pencil grip. So first you're going to pull the pinna upwards and backwards so you could open up the canal. You're going to place a speculum at the ear canal, and you don't want to go in because you want to wash your way into the ear. So you're going to look in the ear. Once the tympanic membrane comes into view, you're going to rotate the speculum to view it, and you're going to inspect the membrane for any color, clarity, and position, and you also want to identify key landmarks and look for any abnormalities.
Tell me if it's tender.
It's fine.
And the back. And the same on this side.
Just a little bit.
Alright.
Not too bad.
And then the back.
Yeah.
Right. And then I should go to the back.
Okay.
Would you mind just unzipping your
Yeah.
top? And I'll just feel for any glands now.
Okay.
Okay. This is a special torch for looking into your ear.
Okay.
Okay. I'll start by the left side first. I'll pull just a little bit, so let me know if it's uncomfortable. There is just a little bit of inflammation in the ear canal, but otherwise everything's fine.
Okay.
And then on to this side. We'll do the same again, so alright. Let me know if it's uncomfortable. Your ear canal is quite swollen and there is a little bit of discharge. There's also quite a bit of inflammation there. The eardrum looks fine.
Okay.
Okay.
We'll start the examination of the outer ear by exposing the whole ear by putting aside any hair and just looking for any signs of inflammation, and also particularly at the back, checking the mastoid isn't tender and swollen and inflamed. And I often ask the patients very gently if I move their ear whether it hurts. So may I move your outer ear gently?
Yes.
Because if they've got an otitis externa, that would be very uncomfortable. And what I do is this: just gently pull up and back. Is that okay, Narushi?
That's okay.
So this is a typical otoscope with a speculum that has a small bevel that rotates on to make sure it doesn't fall off. You turn it on, and it's important to realise that this is for holding the batteries. This is not for grasping the instrument. The best way is a 2 fingers and thumb approach from underneath, which is a very delicate way to hold this instrument. It frees up your little finger, which can then be placed against the cheek, especially of a child who may move suddenly, and if that was to happen, you move with them. So, very gently, as before, we've checked that the ear is not tender, and in an adult, it's helpful to straighten the ear canal by gently pulling the pinna up and back like this. There's no real need to do that in a child, and indeed children rather resent that and start reacting rather adversely if you do that.
and they have quite straight canals, but in an adult it can be very helpful to straighten the canal. Then very, very gently, looking at what you're doing, not looking through the lens at this point, you place the end of the speculum as far as you can see without hurting the patient. You don't want to ram it up against their external canal. And that's as far as I can see, obviously. And now you look through the lens, and you'll often find initially that you're looking directly at the skin of the external canal. And then you have to very gently move it, so usually towards the nose or the forehead of the patient, usually anteriorly, before the tympanic membrane comes into view. And you will only see part of the tympanic membrane at this point. It's important then to be moved gently, move up, move to the down, and move slightly posteriorly and further up. And you are looking initially for the light reflex. That's a very good place to orientate yourself for the light reflex, to make sure it looks normal, to make sure that the tympanic membrane is a nice pinky grey colour that's glistening. And then keep going, looking all the way in the pars flaccida and in the attic region. And then, having finished, just gently coming out. And now to examine Noroshi's right ear, we change hands. So you hold the instrument in the left hand for the left ear and the right hand for the right ear. Again, gently extend and pull back the pinner. Gently place the tip of the speculum in the external canal, and then look down the lens before you can move it slightly to gain a good view of the tympanic membrane.
Moderate earwax accumulation. Tympanic membrane is visible, clear with a good light reflex. Okay. And excessive earwax accumulation. Tympanic membrane is slightly visible, but the light reflex is visible and it is clear.
Okay. Important clues about some conditions that may affect hearing can be obtained through an otoscopic examination of the client's ear canals.
Good. And we'll just check the other one.
Otoscopy also establishes whether the patient's ear canals are sufficiently free of wax or other debris to proceed with testing.
Yep. So next I will look into your ears, okay? Any pain when I move your auricle?
No.
Okay. How about when I wiggle this part?
No.
All right. Okay, and then we'll repeat the same here. Any pain when I move your auricle?
No.
How about that part?
No.
Alrighty. Great. Everything looks great.
Good.
And that is how you use an otoscope.
Begin with pinna examination.
So examination of the pinna looks normal. There's no preauricular pits, there are no end oral scars. Folding the ear forward, there's no postauricular scars. And on palpation of the ear, there is no Barhart abutments, mastoid divot, or cochlear implant. Tilting the head away from us to examine the external ear canal. We choose the larger speculum. We can see that the external ear canal is normal. There are no osteomas, no obstructing lesions, and the skin is normal. Moving on to the tympanic membrane, we can see that the pars tensor is normal, and tilting the head further away, we can see the pars flaccida is normal. There is no evidence of retraction pocket, there are no masses, there are no Schwarz's sign. I like to perform a pneumatic otoscopy to assess the mobility of the tympanic membrane.
Lay the child on her back, on the bed, or on a blanket on the floor.
It may be helpful to have a second adult hold the child's legs or body to prevent sudden movement during the exam. Gently press the child's head to the side to be able to record a video of the ear. Press the camera button to begin recording. Gently pull the outer flap of the affected ear downward and backward to straighten the ear canal. Every child's ear canal is different, so you may need to pull harder on the outer ear for some children. Insert the tip and view the magnified image on your iPhone screen. Once you have been able to visualize the eardrum, pull the otoscope out of the child's ear.
I now need to examine your ear. This will involve me having a look at the outside of your ear and then placing the otoscope inside your ear to have a look at the inside eardrum. Is that okay?
Fine.
I'm now just going to have a look on the outside of your ear. Is that okay?
Fine.
I'm now going to pull back on your ear. Let me know if you feel any pain.
No.
I'm just going to place the otoscope inside your ear. Is that okay?
Fine.
So the first thing you should do is comment on any wax in the ear or any abnormalities you see, including an inflamed ear. Next, you should move the otoscope further into the ear until you can see the tympanic membrane and the landmarks. This is an example of a normal tympanic membrane. Here you can see the handle of malleus, the light reflex, the pars tensor, and the pars flaccida.
Hello Omar, my name's Amy. Would it be okay if I examined your ears?
Yes. Inspect the pinna, noting its shape, size and any deformity. Gently assess for tenderness by pulling on the pinna and pressing on the tragus.
Is this sore?
No.
How about this?
No. Inspect the meatus. Is there evidence of previous surgery? Select the largest speculum that can be inserted comfortably and explain what you're going to do.
I'm going to look inside your ear now.
Get a comfortable grip of the otoscope and rest the ulnar border of your hand against the patient's cheek. Gently pull the pinna to straighten the canal.
Initially, let's look at the external ear, and specifically signs for scars. Look for the presence of an endoral incision, which would come up here. Examine the area behind the pinna, at the mastoid process, for the presence of a postauricular incision. Next, the structure of the external ear and pinna are examined. Observe the helix and antihelix with its two crura, which form the triangular fossa. Observe the tragus and antitragus and the intertragic notch. This is the conchal bowl, which is divided into the concha cavum and concha cymba. Examine the ear lobule. Observe the structure of the ear, in particular the skin, and look out for signs of erythema, swelling, or inflammation. Having examined the external ear, let's look at the external auditory meatus, using an otoscope with a suitably large speculum to fit comfortably in the ear. Pull the pinna superiorly and then posteriorly and look into the ear, past the hair-bearing skin to examine the external auditory meatus and the tympanic membrane. Here you can see the tympanic membrane and the annulus around the edge of the eardrum, and the following anatomy. Malleus, long process of incus, promontory, stapedius, and the chorda tympani. The shiny area here is a light reflex, which is an artifact from the otoscope. Finally, the round window is identified.
This is an otoscope. I'm going to be using the otoscope to do an otoscopy, and I'm going to look into your middle ear to make sure that it's clear, that the color is transparent, and that your middle ear looks healthy before we do our audiological testing and tympanogram testing. The first thing I'm going to do is turn the otoscope on. You can see the light. And what I'm going to ask, first I'm going to look on the outside of your ear to make sure there's no obvious abnormalities. And now what I'm going to ask you to do is tilt your head for me a little bit. And I'm going to look into your ear. I'm going to pull your pinna up. I'm going to brace with my 2 fingers. And your ear looks clear of wax. I see your cone of light. And I see your tympanic membrane. And everything looks good over there. Now I'm going to do your other ear. Sorry. Tilt your head for me, please. You have some wax in this ear. It's a little hard for me to see. I see, oh, I'm sorry, it's okay. I see a little bit of the cone of light, and I'm gonna refer you to an ENT so we can remove some of the wax for you.
You might be able to see that I have a little bit of earwax in my ear, but it's not anywhere near enough to block my ear canal or occlude my eardrum. So I have a normal amount of earwax right now. If you would like to have your ear examined with a video otoscope, give us a call. It's free, and it's important that you have it done.
So first off, I just want to start just kind of looking over your ear here. So just one piercing. This baby hair is always getting in the way. Looks like there may be a little dryness on the inside, but nothing bad. See, you do have you have some scarring from your piercing. Gonna kind of fold this a little bit. Okay. Just gonna look with the light now. Touch your head. Okay. Okay. C2. There it is. I have some wax built up in there. I'm sorry. Let's see if I can get it from this angle. Nothing too bad. I'm going to take just a real quick look on this side. I know this is the one that's always gave you problems. I think you might have a small blockage on this side. So we can plan on getting you in to get that cleaned out.
You pick up the otoscope. It is best to hold the otoscope like a pen, like this. The reason we use this position because we can maneuver very easily the otoscope. If you hold like that, your grip is very tight and it is difficult to maneuver, and if you are looking inside, you may cause trauma to the ear canal. So with this you have got a firm but not very strong grip, a steady grip, and you can easily examine. Whenever you are examining, you must use this oral speculum, which you put it there and turn around, and then it fits into this notch there. I have noticed even during the annual examination, a lot of students are using without this. So you must use this. And then again, what we are going to look inside the ear, as we did with the seagull speculum, ear canal, any abnormality, any secretion, any pus, any polyp, and then the tympanic membrane, if it is intact, is it normal color, which is a grayish white. If it is normal color, if it is not normal color, if it is red, or which indicates an acute infection of the middle ear, which we call acute otitis media, or if it is retracted. If there is any perforation, then you must locate the perforation, whether it is anterior to the handle of the malleus, posterior to the handle of the malleus, whether it is in the pars tensa or in the pars flaccida, that is atically. So basically, I am going to focus on clinical examination. I am not going to discuss or explain any pathology in this video. So you switch on from here. There is a small button there, and then you look in on your palm, so that you want to ensure that the intensity of the light is good. Your batteries are charged. Okay. And then again, as I said, you right ear, right hand. You pull up enough upward and forward, and then you look inside the ear canal, like that. Sometimes when the eardrum is retracted, you want to assess the mobility of the eardrum. So for that there are various ways. You can ask the patient to do a Valsalva. What you ask, what is Valsalva? Ask the patient to pinch the nose and blow with their mouth closed like this. So if the eardrum is mobile, it will move. The registration tube is normal, that it may move. The second method of assessing the tympanic membrane mobility is to use the pneumatic bulb, which fits there. You put in the inside the ear and then check the mobility by pressing some air. Okay. So first of all, and then you look inside like that, and then you can look with the otoscope as well. Now going to move like, okay. And then with the pneumatic speculum, so you hold it like this, and you check the mobility. Okay. just now, a few seconds ago, I held the otoscope like that just to demonstrate that this is the wrong way to hold it. You must hold it like this just to emphasize my point. Okay?
Let me know if there's any tenderness. Any tenderness? I'm going to be placing this into your ear. Let me know anytime if this is tender, okay? Tilt your head away again. Everything okay? Mm-hmm.
Begin the ear examination by inspecting the auricle for position, size, and symmetry. Also, inspect the opening of the ear canal for discharge, swelling, or redness. If the patient has complained of ear pain or if you see signs of inflammation, check for tenderness by moving the auricle up and down and pressing firmly on the tragus. Pain on these maneuvers suggests inflammation of the ear canal. Also, press firmly on the mastoid bone behind the ear. Tenderness here suggests middle ear infection. Next, examine the ear canal and eardrum using an otoscope. To do this, select the largest speculum the patient's ear canal will accommodate. Position the patient's head so that you can see through the otoscope comfortably. Grasp the auricle firmly but gently, and in an adult, pull it up, back, and slightly out to straighten the ear canal. Then insert the speculum gently into the ear canal. Note any cerumen or earwax that may impair your view. Also observe for any discharge, foreign bodies, redness, swelling, or scaling. There should be none. Slide the speculum slightly down and forward and maneuver it until you can see as much of the eardrum as possible, including the pars flaccida, if possible, and the margins of the pars tensa. Note the color and contour of the eardrum with its distinct cone of light. Normally, the drum is pearly gray. Also, note the position of the handle of the malleus and inspect the short process of the malleus. The handle of the malleus, with the umbo at its tip, crosses the drum obliquely from the cone of light upward toward the short process.
Let me know if anything bothers you. Okay. Okay, now I'm going to check your other ear. Okay. Let me know if anything bothers you or if it's painful. Okay, it doesn't hurt. Okay, looks good.
We'll now talk about the examination of the external auditory canal, the tympanic membrane, and the middle ear space. When we're examining these structures, we use an instrument called an otoscope. An otoscope also has an attachment on the side of it here to which a bulb can be attached. With this bulb, I can pump pressure through the otoscope and actually see the tympanic membrane moving. If the middle ear space contained fluid, the tympanic membrane would not move. So it is a very good diagnostic tool for diagnosing things such as an otitis media with an effusion or an acute otitis media with pus behind the eardrum. Before I insert the otoscope, I need to use my ensure that I do not cross my hands. So I use one hand to grab the pinna of the ear and pull it up and outwards in order to straighten the external auditory canal. The next thing I do is I take my otoscope and I rest my hand on Brittany's cheek here and insert the otoscope into her ear, taking care not to go too deeply, as this will cause her pain if the otoscope actually contacts her bony external auditory canal. Then I can look through the otoscope and examine the necessary structures of her ear. So I've now moved to Brittany's contralateral right ear, and I'm going to examine it. As you will see, that I need to switch the scope from this hand, my left hand, to my right hand now, in order that I don't cross hands. I now use my left hand to pull on Brittany's pinna to straighten the external auditory canal out. This is also an important clinical finding in otitis externa. If Brittany had inflammation of her external auditory canal, this would cause her significant pain. Again, I rest my finger, my little finger, on Brittany's cheek here, and then insert the otoscope. The importance of this type of physical examination or formation of my hands is that if Brittany were a small child and if she moved her head, my otoscope would move with her. If I was not resting my hand on Brittany's cheek and she was a little child, she would move her here and the otoscope would injure her external auditory canal. This is why it's important to rest your hand that's holding the otoscope on your patient's cheek and then insert the otoscope. We're going to use a rigid telescope or endoscope here and insert it into Brittany's ear to highlight the important structures that you should be seeing when you look with an otoscope. So I'm going to pinch, again, grab Brittany's pinna here with my thumb and my index finger and pull and straighten out that external auditory canal. And the part that I'm straightening out here is the membranous or the cartilaginous portion. As I insert it and move past the hairs of Brittany's ear, we can see the bony external auditory canal and a beautiful view of her tympanic membrane. We can see, I'm just trying not to hurt Brittany here. We can see here the annulus of the eardrum, the malleus, the incus, the stapes, and the chordae tympani nerve running across the eardrum. The eardrum is in normal position, it has no perforations, and the middle ear space appears relatively clear. And here is the round window of the middle ear as well. Okay?
Let's take a look inside. So, I'm actually just going to inspect the outside first. So, just looking for any signs of infection or any clogged pores or anything like that. I don't see anything of concern. Then I'm just going to go inside. Just pulling the top of your ear. Just let me know if you feel any discomfort, okay? Okay. I'm going to go a little bit deeper. So far the canal looks really good. There's a bit of cerumen, but it's quite healthy yellow color. And I'm just going to visualize the tympanic membrane. It does look a little bit white, so slightly opaque, but I'm still able to very clearly see the cone of light and the bony landmarks. There's a little bit of vascularity, which I think is normal. Is that uncomfortable at all? Or is that okay?
No, feels fine.
Okay, I'm just going to go in one more time. I don't see any signs of infection. And the ear canal looks a nice flesh color. Yeah. So no contraindications on this side for the ear candling, so that's good. Great. Let's take a look on the other side. Again, we're going to start with inspecting the external ear. The skin looks very healthy. Great. Clean. We'll do a little bit of cleaning before the ear candling. So I'm just going to pull the pin out of your ear and work my way in a little bit. And again, just a little bit of cerumen. It's a nice yellow color. And then the ear canal is also not red. That's good. Okay, I can see the cone of light. There's no signs of bulging of the tympanic membrane, no perforations, bony landmarks are present. It's a nice translucent membrane, so that's good. This ear looks very healthy, and again, no contraindications for the ear candling procedure.
So I'm just going to go ahead and look in your ear. I'm going to look at the canal. Okay. And I'm assessing the ear to look at the inner structures, the tympanic membrane. Look, make sure there's no bulging. Note the color. And I don't see any scarring. Wonderful. We'll do the same for the other ear here. No pain. Nope. Okay. And I don't know any abnormalities or lesions on the ear. I'm assessing for the same things in this ear. I don't see any scarring, redness, no inflammation, no drainage. And that looks really good.
Extend your little finger and use this to rest against the patient's face. This means that if the patient moves his head, your hand and the otoscope will move with it, and the otoscope will not stab into the ear canal and cause pain. This is of particular importance when examining children. With your free left hand, pull the pinner gently upwards, outwards and backwards to straighten the external ear canal to allow a better view of the tympanic membrane. In children, pull the pinner down and back instead. Insert the otoscope into the external auditory meatus and inspect the canal for wax, discharge, inflammation and other abnormalities. Gently proceed down the canal until the tympanic membrane is seen. Move the speculum around to examine the whole of the tympanic membrane and identify the normal landmarks. This is a normal right tympanic membrane. On a normal tympanic membrane, you should be able to see the handle of the malleus, the light reflex in the anterior-inferior quadrant, and the pars tensor. You should look superiorly to see the pars flaccida also. Gently remove the otoscope, continuing to observe the ear canal for any pathology that may have been missed on the way in. Repeat the examination on the other ear. When examining the left ear, hold the otoscope in your left hand, again holding it like a pen between your thumb and index finger, and using your little finger to rest against the patient's cheek.
Go ahead and look inside your ear. So your ear canal is clear, no impaction, erythema. Your tympanic membrane is pearly gray, which is normal. All landmarks visualized. I'm going to check the other side. Any pain or tenderness? Excellent. All right, tympanic membrane is pearly gray on this side as well. All landmarks visualized. A small amount of brown cerumen in your ear canal, so you just got a bit of earwax.
Okay, in your ear canal, there's no redness, discharge, swelling, or lesions. Your tympanic membrane is gray, shiny, is pearly gray, shiny, and translucent. Your umbum and manubrium and short process are all visible, and your cone of light is present in your left ear at 7 o'clock. And I would do the same assessment in your right ear, and everything would be the same, but only your cone of light would be visible at the 5 o'clock position, not the 7 o'clock.
Do the Otoscope exam now. I'm examining the external auditory canal, the tympanic membrane, the malleus, umbo, and cone of light. You're going to feel a small burst of air as it tests the tympanic membrane mobility with infiltration. Now I'm going to look in this ear, examining the external auditory canal, the tympanic membrane, the umbo, malleus, and cone of light, and you're going to feel a small burst of air as I test the tympanic membrane mobility with insufflation.
When I look inside the ear, I'm going to use the biggest speculum that fits. I'm going to pull up and back for an adult, and I would pull down for a child. I'm going to pull up like this and look inside. And I'm looking for the tympanic membrane. And there's no evidence of any cerumen or foreign body, and I see the tympanic membrane in there. It is pearly gray, no evidence of any distension or anything, no scar tissue, and the light reflex is about 5 o'clock, so that's good.
Just continue looking straight ahead.
And then I'm going to check tympanic membrane motility by insufflating. Okay.
Okay. Okay, your ear canal has no obvious lesions, bleeding, discharge, or redness. Your tympanic membrane is pearly gray, shiny, and translucent. Your umbum manubrium and short process are visible, and your cone of light in your left ear is present at 7 o'clock. And then I would do the same thing on the other ear, but the only difference would be that the cone of light would be at the 5 o'clock position instead of 7 o'clock, okay?
Next, examine the ear canal and eardrum using an otoscope. To do this, select the largest speculum the patient's ear canal will accommodate. Position the patient's head so that you can see through the otoscope comfortably. To straighten the ear canal, grasp the auricle firmly but gently, and in an adult, pull it upward, back, and slightly away from the head. Insert the speculum gently into the ear canal, directing it somewhat downward and forward, bracing your hand against the patient's face. Note any cerumen or earwax that may impair your view. Also, observe for any discharge, foreign bodies, redness of the skin, or swelling. Maneuver the speculum until you can see as much of the eardrum as possible, including the pars flaccida, if possible, and the margins of the pars tensa. Note the color and contour of the eardrum with its distinct cone of light. Normally, the drum is pearly gray. Also, note the position of the handle of the malleus and inspect the short process of the malleus. The handle of the malleus, with the umbo at its tip, crosses the eardrum obliquely from the cone of light upward toward the short process. Be sure to examine the other ear in the same manner.
Examine the ear through inspection and palpation of the auricle and its surroundings. Observe shape, color, swelling, masses, deformities, skin lesions, or discharge. Check if the patient has tracheal tenderness. Do this for both ears. Otoscopy must be done with proper handling of the otoscope. Hold the pinna and gently rotate the auricle backward and upward. This straightens the ear canal. The speculum is inserted slowly into the canal without touching bone. Inspect the ear canal and all quadrants of the tympanic membrane. Note cerumen, color, lesions, or foreign body. Perform otoscopy on both ears.
Okay, I'm going to examine the inside of your ear. Okay, as I said before, use disposable towel. Okay, use a new earpiece, and in examining the right ear, hold the otoscope with your right hand and just straightening the ear pin up, just to straighten the external auditory canal, and look inside the ear. Okay, I'm seeing now the tympanic membrane, and I see now the light. This test is a little painful, so do it very gently in the CS examination, and also consider that stentoritis patients are exposed to many ear examination in the CS exam. When examining the left ear, stand on the left side of the patient, hold the otoscope with your left hand, again straight the ear pin up, and introduce the otoscope very gently. Okay, and I'm seeing now the tympanic membrane and the cone of light. Okay, thank you so much.
I'm now going to look inside the ear. This will involve me pulling back on the earlobe and then inserting the otoscope into the ear. If it's at all uncomfortable, do let me know. Okay, sure. Great, we'll now examine the other ear.
So now I'm just going to look into your ears. Do you have any earaches, or have you had a stopped up ear, anything like that?
Oh, this one might be a little weird.
Okay. Yeah, you have a little drainage in that. Okay, the outside of your ear looks good. I'm going to move to this side.
Attach a new disposable ear tip or speculum. It's best practice to examine the healthy ear first. This allows you to see the patient's normal ear anatomy and compare to the other ear, while helping to prevent the spread of infection. Straighten the outer ear canal to make insertion of the speculum easier. Guide the otoscope into the patient's ear to view the canal and tympanic membrane. Adjust the focus wheel during the examination if necessary. With a basic otoscope, you may need to pan around more to get a complete view. After the examination, the used disposable speculum should be removed and discarded. Twist the speculum off by hand or rotate the MacroView tip grip to eject the speculum. The insufflator bulb can be used to help determine if there is fluid behind the eardrum, which can be a sign of infection. Using well-challenged soft seal tips can help provide a better seal against the ear canal wall, making it easier to see movement of the tympanic membrane.
I'm going to pull the pinna up and back before I insert this into the ear canal. So when I'm inserting this in the ear canal, I'm looking for what's called the tympanic membrane, or the eardrum. And the reflection of the light from the otoscope will make what's called a cone of light on the tympanic membrane.
To examine the patient's ear, hold the otoscope in your dominant hand. Between your thumb and fingers, pull the pinna of the ear up and back to straighten the ear canal. Remember, you'll need to look in all directions to view the entire tympanic membrane or eardrum. Now inspect the external ear canal. You should not see redness, lesions, swelling, or exudate. Now examine the tympanic membrane or eardrum. It should reflect the otoscope's light and should appear shiny and gray with a white periphery. Its center should be concave with no perforations. Note the malleus and the light reflex. Occasionally, you may see the incus. Finally, withdraw the speculum. If you see exudate on it, change the tip to prevent cross-contamination.
Alright, you have minimal cerumen, which is good. I do see some like flakes, but that's fine. Alright. Any tenderness there? Okay, good. I also don't see any redness or bleeding or foreign bodies, which is great. Right now I'm looking at your tympanic membrane. It looks nice and healthy. It's a good pale color. I don't see any edema or perforations. I also see the umbo, which is at a good angle, and it also does not have any like redness or swelling on it. I don't see any scar tissue, which is great. Alright, I am unable to see the cone of light, but if I could, it would be towards the bottom of my visual view here. Alright, looks really good. And then normally I would look into your other ear as well.
The otoscope exam allows for examination of the external canal and middle ear. With a disposable specula on the end of the otoscope, hold it like a pencil. Use your little finger side of your hand to stabilize the otoscope from going deeply into the patient's ear. With your hand, gently pull up and back the ear. Work gently and quickly to observe the colors of the tympanic membrane in the canal. Look for the cone of light reflex on a pearly gray tympanic membrane.
Okay, noting that the canals are patent, the team has visualized it's pearly gray and translucent. Landmarks are also visualized. We'll do the same thing on the other side. Tender there?
No.
Here? Nope. Okay, take a look in the ear. Okay. And again, the landmarks are visualized with the cone of light, the umbo, and the malleus.
Looking in for any discharge or swelling. Also, I'm going to be looking for the tympanic membrane inside and also the cone of light.
The instrument may either be held this way to enter the canal or this way. Either way is acceptable. The most important part, though, is pulling up, out, and back to straighten the canal. In doing such, you will straighten the canal, place the speculum into the external auditory canal, and visualize the external canal and the tympanic membrane. You'll notice the malleus, the umbo, the light reflex pointing anteriorly, and perhaps other ossicles in the middle ear. To examine the left ear, the examiner uses his or her right hand to pull on the tragus and earlobe up, out, and back, and the otoscope can be entered into the external canal either as was demonstrated on the other ear or held in this manner, and the speculum is inserted as I'm demonstrating now.
Next, I'm going to take a look in your ears. And I notice that the canals are smooth and pink and free of swelling, discharge, lesions. And I can see that I can visualize the tympanic membrane and all of the ossicles there, as well as the cone of light. So we'll take a look at this side. And again, the canals are smooth pink without debris, discharge, swelling, or lesions, and both tympanic membranes are gray with clear landmarks and a cone of light present.
I'm going to have the patient tilt her head. You're going to hold the otoscope like a pencil, placing your fingers against the patient's face in case they move, and then gently insert the otoscope. And while inside, I can see that she has minimal wax. I see the cone of light and the malleus. Okay.
Now I'm going to do the same thing on the other side. You're going to hold it in your left hand like a pencil. Same way. Do a visual check first. Pull up the pinna to make sure the ear canal is not collapsible. Tilt your head. Again, place your fingers against the patient's face and insert the otoscope. Okay, and the same thing in here. You can see there's also minimal wax on this side, the cone of light, and the malleus. Okay. So there's no need to refer her, but in the event that you do need to refer, if there would be blood in the ear canal, a foreign object, or if you can smell the odor of an infection, and then they would be referred to a doctor.
Hello, my name's Misha. I'd like to examine your ear today. Is that all right?
Yes, that's fine.
Great. Thank you. I'm going to examine the other side now.
That's fine.
And you place it in, and what happens is now I got a good seal, and the patient will tell you it doesn't hurt. You can actually press kind of firmly. Then you hold this in this hand, and what you're going to do is, when you're visualizing, you're just going to kind of go like this. That's all you need to do. If you have a good seal and you do this, you will hurt the patient, and maybe, I've never blown an eardrum, but I guess you theoretically could damage the eardrum if you do this kind of action. So I've seen people do this kind of action, but without a good seal, it won't damage it, but it's not very effective. So when you do this, you tug, and then you just show the bulb here. You just do this kind of action, okay? Your instrument, pull back, and then start. Once you visualize the eardrums, yeah, hers goes in and out very easily and it doesn't hurt, okay?
Always steady the hand that holds the instrument on patient cheek and examine the entire tympanic membrane. Here, he has an intact tympanic membrane, pale gray, glistening of semi-transparent quality. Long process of incas is appreciated and cone of light is preserved. While in left side, he has ear discharge, which is yellowish, offensive, with central perforation.
If I place the speculum here, just gently on Satish's tragus, see how I'm just placing it just inside the ear canal at the tragus. Why am I putting it there? Because that gives me a place to rest it so that I know where I am before I start looking through the lens. What you want to do is have your speculum stay in one place, not go any deeper than this while you're looking through the lens. So I've got the speculum held at the tragus, and notice also that I have my hand against his cheek. So I'm bracing my hand against his cheek, and if Satish moves his head, move your head a little bit, Satish. If he moves his head, I'm not going to be pushing the speculum into his canal because I'm bracing against his cheek. So that's critical. I'm braced against his cheek, and my speculum is just resting against the tragus of his ear. That's when I look in through the lens. And already, with the speculum going in no further than it is now, I can see what I want to see. Just by moving my head here and changing the angle of my vision, I can now see the short process of the malleus. I can see the malleus itself, and now the umbo and the light reflex. Notice I'm the one who's doing the moving, not Satish.
And I'm the one who, by orienting, not moving the speculum in any further into the canal, but just by orienting it differently, I can see what I need to see on the tympanic membrane. So moving over to the other side, here I am with my otoscope again, but now I'm going to change hands. Now I'm holding the otoscope like a pen in my right hand, and that frees my left hand to pull the ear up and out like I was before. The short process, the malleus, the umbo, the light reflex, all visible from this distance. If I want to get a closer look, I can move in. But really, everything is visible from back here with the speculum barely in the ear canal. Now, of course, it's easier because Satish doesn't have a whole lot of wax in the way, and smaller children will have smaller canals, and they may have an accumulation of wax. But in my experience, by pulling on the auricle and moving it around, you can straighten out the canal a whole lot and really make your life a lot easier in visualizing the tympanic membrane. Better that than trying to shove this long speculum into the ear canal and risking damaging skin or hurting the patient and making them fear doctors for life.
Take her ear like so and pull directly back. My hand will go on the side of her face for an anchor, and I'll use the tip to simply slip the tip into her ear, and so that it's good and centered. Then I will visualize. I can see the gray shiny of her tympanus and no evidence of inflammation or anything else. You have the cleanest ears I've ever seen. Okay? Very good. All right. Now, if there wasn't inflammation, it would be easy to see because it would look like a sunset. Okay? You also have to watch out for blockages, growth, and things that may go bump in the night. Okay? Again, nice clear tympanus, no signs of inflammation, no wax, nada. Okay? Very nice. My ear should look so good.
I'm going to pull up and back on your ear, and if I cause you any discomfort, just let me know, okay? I'm going to put a pencil and rest it on the ear. Ease into. See a light reflex. Very little wax. Malleus. No drainage. Pearly gray. Very good. You see it? I'm going to pull up and back on this one. Into. Light reflex. No wax. Pearly gray. The handle of the mallet. And no odor. Very good.
In using the otoscope to examine the ear, pull gently posteriorly on the helix, a maneuver that straightens the normally S-shaped canal and allows for better visibility. One should use the largest speculum that the ear canal can accept, as this increases visibility.
Another way to hold the otoscope, which is especially helpful in children, is in a rather upside down position, which gives added stability.
It is important to remember that when inserting the speculum to stay on the cartilaginous canal. As already mentioned, the bony canal is quite sensitive. You need to remove any wax out of the way to better visualize the tympanic membrane. The tympanic membrane may be silver or gray in color and translucent or opaque. The most prominent anatomic feature of the tympanic membrane is the handle of the malleus, which sits in the tympanic membrane and is somewhat anterior in position at its distal end. Extending from the distal end of the malleus, also known as the umbo, is the light reflex. This will help orient you towards the anterior-inferior aspect of the tympanic membrane. it is important to remember that the presence of a light reflex doesn't necessarily mean that there is a normal middle ear. The light reflex is important in evaluating pneumatic otoscopy for the mobility of the tympanic membrane.
Now I'm going to assess the tympanic membrane mobility by puffing some air into your ear canal and checking the movement of the tympanic membrane as I do that.
This needs to be done and documented on every pediatric patient and be accomplished on every adult whenever possible. In the pediatric patient, the tympanic membrane may appear to be normal but have no mobility, suggesting the presence of an effusion in the middle ear.